Thank you, Peter. Thanks very much. Great. Hope you can hear me. We'll be sharing screens in a moment, but I just wanted to say welcome to the breakout group, breakout 1, it says on my agenda. This is a clinical safety breakout session, and we were moving into just a brief talk through a number of slides for us. So welcome to you all. Hope you're in the right group, and I hope you can hear and see me okay. There's this reliance on my internet always, but Clive, who's with me, and Maggie are on backup. So if Duxford Airfield takes off and starts interfering with my internet, where I'm situated near, then we're all set for standby. So very warm welcome to you. I'm just going to do a quick just going to share my screen. I hope you can see my screen now, Clive and Maggie. Yep, great. Yep. So just a quick intro slide. We are recording this session as always, and we are going to encourage active participation and interaction during the next 50 minutes. We've got until 3:20, so we hope it'll be a useful 50 minutes spent. And this is really to help inform us in the safety team at the faculty. And I want to do some brief introductions first, not around the whole group, but I may ask for introductions when you speak, but just from the facilitators, if I can call them that. So just for myself first, so Sebastian Alexander, I'm actually a general practitioner in Cambridge, but I also work for the clinical safety team for NHS Digital 3 days a week now, and also chair the CSG, the clinical safety group. So I may have met some of you on CSG or the clinical safety group. I work with the clinical safety team and for NHS Digital, and I'm also a founding fellow of the faculty and very much an enthusiast of having this organisation present to help all clinical informaticians through this process and development. And I wish it was had been around 20 years ago. I've been with NHS Digital in my strategic clinical lead for safety for the last 10 years. And before that, I was working with as a national clinical lead on the ERS, Electronic Referral Service Programme, or Choose and Book as we used to call it in those days. So that's a bit about me. Can I hand over to Maggie first and then Clive? Maggie first.
Hello, I'm Maggie Lay. I'm a nurse, community nurse by background. I'm clinical safety officer and I work currently for South Central and West Commissioning Support Unit. I've been making up clinical safety for 0160 for the last 10 years. And as like Sebastian says, we needed a group like this a long time ago. And yeah, so I'm a clinical safety enthusiast and trying to make it workable.
Thanks, Maggie. Clive.
Yeah, hi, I'm Clive Thompson. Like Sebastian and Maggie, I'm quite passionate about this, clinical safety. I've been doing it, I don't want to give my age away, for over 20 years now. Humble beginnings back with the National Patient Safety Agency and the national programme. More recently, I've joined Maggie working for South Central West, supporting DTAC, as well as a few other interests. And my other interest is clearly with the faculty, supporting the work that Sebastian and others are leading. So it's a great privilege to be here today. Thank you, Sebastian.
Okay, thanks very much. And I can't quite see at the moment how many others we've got I haven't counted up members, but we may take some general questions later. So if we do, we'll ask you just to say who you are if you could, rather than going around a formal round table now. But we're going to spend this kind of half an hour, 40 minutes, talking about the survey that was sent out by the faculty. And before we do that, I'd just like to say that we have performed, when I say we, I mean Connecting for Health, have performed a number of surveys across across the strategic, the SHAs as they were then, and clinical safety officers in the past. And I think the last one actually, and some of you may remember this, we did a survey back in 2011 to 12, when we sent out surveys to the then 10 strategic health authorities around predominantly clinical safety questions. So such as, have you got a clinical safety officer? Do you know about the standards? They were called something else then. I think they're called ISB standards then. rather than the DCB standards, and some general questions about roles. And so we did gather responses, but the purpose of the faculty's questionnaire, which was sent out about a month ago, sent out to all faculty members, associates, and fellows. So I'm told about 1,000 were emailed the questionnaire, and we had a response from about 60 or 70, which isn't bad, I suppose, because the response was actually naturally targeting those who are actually in a clinical safety role, and not all the individuals in the faculty obviously work in clinical safety. So what we thought would be useful to do would be to go through the answers to those particular questions and the responses, and then we formed a kind of a Clive and Maggie kind of chat for each slide to kind of get you thinking about the answers to those questions. And this kind of brings me on to the objectives, and we're really not going to talk at you for this length of time, but we really want some of your feedback around some of the responses to the survey, but more importantly, how can the faculty of clinical informatics help you in the development of your role? And going back to my own kind of just on a personal note, as I said, I wish I had the faculty around all those 10 years ago. It would have been really useful to have the faculty there helping out with some of the dilemmas that we were kind of going through at the time, because it's a very lonely role as a clinical safety officer. There are developmental needs that are needed as a clinician and a clinical safety officer, whether you're in social care or allied health professional or whatever. And I think that's it's a very poorly supported role at the moment. So really ask yourself as we're going through these slide sets, how can the faculty help in development of your role? Also think about what are good parts of your role if you're a clinical safety officer at the moment, what are bad parts, and also what could be improved. How can we make the job better, and how can we make it easier for you to do your job out there in the trusts or in CCGs or wherever you may be working in health and social care. And then we're going to also try and coordinate some of the comments through chat. And again, the chat will be recorded again, but Mag is going to help coordinate some of the discussion points in chat. And we're going to spend the last 15 minutes of the session just trying to take some general points away. So we as a SIG group in the faculty can start working on some of these ideas that you're going to come up with. So it's not about me, Maggie or Clive suggesting things. It's more about the group, and you are all interested in safety. That's why you're on this session now, is to try and come up with some ideas that are novel and will help us all going forwards in time. So that's a little bit about objectives. And I'm sure I've missed something off there, but I'm going to just turn to Maggie and Clive. Was there anything else you wanted to add in on that little introduction?
Sorry, Maggie. Sebastian,
no, you go ahead.
We suggested that maybe the participants might just add to the chat what their role was, because it just gives us a flavour of those participating, what areas they've come from and what their present role is. So maybe in the chat, CCIO or CSO or other, just to give us a picture of those people participating, because otherwise we just get to know the numbers, really. Yeah,
that's a good idea. Thanks, Clive, for reminding. So while you're, that'd be really good to do early on, so we get a flavour of where you're coming from. So while we're just talking and changing screens and things, so if you could do that, just your current role, whether you're clinical safety or not at the moment, and who do you work for? CCG, NHS Digital, or whoever, social care. While Maggie's going to say something. Maggie,
I'm going to say thank you, Andrew, for putting that down there already, and Clive. Thank you, Clive. We wondered who you were. And so the other thing I was going to say is that many of you may have been on the NHSX series of discussions about clinical safety, and you may well be thinking, is this more of the same? We hope this is going to be faculty based. We hope this is going to be, not that NHSX weren't asking us for our opinions, but this is about our opinions. We don't make the strategy, but we represent the clinical safety officers. So this is a slightly different approach. Say the same things if you want to, and we'll respond to them as we can.
Yeah, I think that's an important point, isn't it? We're here as a kind of almost an independent body, a faculty trying to represent views of our members and our SIG members. And if there are gaps or concerns about current process, don't be shy and put those in the chat, and we can then talk about them. Because I think it's one of the roles of the faculty to try and bridge some of the gaps that may be or may have developed or whatever. I can't see at the moment see the chat, so I'm relying on Maggie to coordinate the chat a bit. So, but if we can, I don't know whether Maggie, have we got, how many have we got on the call now?
We have got, I'm happy to scroll down through. It looks like we've got about 20, 25.
Okay, well, great. Well, that's a really good number. So welcome to you all again. And do we know kind of how many CSOs there are or clinical safety folk in an active role at the moment?
I can't see at the moment.
Yeah, okay. We'll work
but that's fine.
As people are typing.
But can I just say, those of you who aren't clinical safety officers, welcome, because this is everybody's responsibility. So thank you, digital nurses and everybody else.
Absolutely, yeah, open to everybody, of course.
So Sebastian, there are about, currently with the roles streaming through, there's an 80-20 cut between clinical safety officers and, importantly, to Maggie's point, others who are interested and support.
Yeah. And actually, interestingly, isn't it, historically, we started with 8 clinical safety officers, 8. This is about 10 years ago when we did the first survey, which were funded through the SHAs, the Strategic Health Authorities. So that kind of the numbers have gone up exponentially. Okay, so I'm going to move on to the first slide, and we're going to spend about 2 minutes on each slide. Some are going to go over quite quickly. So these are the survey results coming up. So there are kind of 19 questions effectively, and we're going to go through these relatively quickly, but trying to kind of just to invite some comments and some thoughts really. So again, sent out to all the faculty members and associates and fellows, and about number of responses 63 is a number down there. So these are the types of organisations of which the respondent belong to, and I don't know whether there are any particular thoughts on that. I think one of them, Maggie, was where does primary care sit in this? And also we were thinking here about there may be a slight bias in membership. There's no ambulance service there. Are there no ambulance service CSOs or safety persons? And so why weren't certain areas well representative? Obviously, a good percentage from acute hospitals there. And Clive, did you have a question, a comment?
Yeah, I was interested with the emergence of, for example, the healthy intent type platforms that are being generated that are now beginning to include not only healthcare but also social care. There doesn't appear to be any social care representation. Is that an oversight? Is the role of clinical safety officer not something that social care or councils, whoever funds them, have appreciated? It was just that sort of area of interest to the obvious bias to the acute trusts and the vendors. Yeah.
And I know that I know Andy Carr's on the call as well, but Andy and I spend a lot of time doing the training now, and we do train social care in clinical safety as well. So there are whether that's just a natural gap, I don't know. So I think it's a very crude measure, isn't it? This or a very crude set of questions, but we may think about refining this and trying to look at some further inquiries around that.
So Anne is saying, hello Anne, that she's an ex-ambulance service member. She's never known one to have a specialist safety officer role, okay. And that's fine. And I think back to the point you mentioned something I said earlier, Sebastian, which is where do GPs fit in? My feeling was, when I first did the clinical safety training, that it was predicated around acute hospitals deploying a pharmacy system. And so therefore it's been difficult, and certainly from a primary care integration interoperability way, and I'm imagining with the ambulances service, it's harder to apply that to. So And that's fine. I mean, you have to start somewhere, and acute hospitals need to be safe. So it's not a criticism; it's just an observation of the journey so far, really.
But it may be something we can look at targeting attention to, perhaps.
Yeah,
okay.
Exactly.
Okay, we're going to move on to the next slide, if we could, which is, are you, so is the respondent part of a wider team? It's just kind of, this is a simple yes, no answer. Yes, they are. So it's good that they're not just working by themselves. But I often get the feeling that the CSO is quite a lonely role, and they often feel quite isolated. And it's again a question to you: how can we support those CSOs better than we have done in the past? We've been doing a lot of work with the with the NHS Digital around trying to support through the national CSO formers, the national CSO group, National Clinical Safety Officer group, but that's not actually reaching everybody. So we've got the SIG now, the Clinical Safety Group, the Special Interest Group with the faculty. But are there any other ways? So just to kind of think about that a bit. And I think, I mean, you had a comment, Maggie, around other aspects, I think, didn't you?
Yeah, well, I was thinking, because in my role I work most closely with IG, because actually a DPIA is a risk assessment, and often it comes from the same hazards. And so I was interested that didn't appear as part of the wider team. So that's something I've long been interested in, digital assurance rather than clinical safety, where it all fits in.
Yeah. Okay.
Vicky, yes, we can list all those groups so we can look to join. I can't do it now. Sorry, Vicky is asking if all those groups you mentioned, Sebastian, whether we could list them all. We will perhaps do a little bit of a mapping of these groups and post it somewhere and let you know.
Yeah. Okay. So groups being different, safety engineers, clinicians, IT roles, or the previous slide.
I'm talking about the different. You were
Yeah.
talking about, Sebastian, the various groups that have existed to support CSOs outside.
Okay.
Yeah.
Okay.
Yeah.
And I just Nick's just kind of turned his camera on. It'd be really useful if you feel able to turn cameras on, then I can just kind of gauge hands and things. If you're comfortable with that, it's always easier for me. I'm in my house outside Cambridge talking to a blank screen at the moment, so it's always helpful to get, especially with a small group. So okay, we're going to move on to the next one, next slide, which is your role specifically concerned with digital health, which is a little bit of a vague question, but the majority say yes and a few say no. And I know that we had some comments around that, Clive, as well. So Clive, did you want to mention?
Yeah, again, I was interested in so much that, I thought it was positive. It's sort of over 85%. So that suggests some recognition of the role. Does that give some indication of a clear patient safety, digital health sort of role being recognised? I thought that was generally very encouraging.
Yeah, I think some roles obviously cover a wider remit than just digital health. And we mentioned earlier about cyber. Sometimes it can be, or you could be an IG lead as well. So I think that's a slight. So yeah. The no's may represent the CSO doing other roles. There may be a medical director as well. Don't know.
Or for example, working in general safety, because I think there is a danger that digital safety and other patient safety is seen as two separate disciplines, and they go alongside each other, really. And in fact, there's a question about whether you by calling it digital clinical safety or referring to it digital, are you creating an artificial barrier? I think it's important to realise there are specific risks around digital that don't exist in other areas, but that they should all be incorporated under the patient safety banner.
And I know that you don't know what the next questions are, but the next slide kind of follows on from that a little bit. The next question was around: do you have more than one digital health role? So yes, and this, I suppose that's kind of the answer to the previous question a little bit, that often these are multiple roles. And I know that in our local trusts here in Cambridge, we have a CSO who that's his main job. He's a full-time CSO, doesn't do much else.
And Sebastian, I wondered to that point, and the previous slide, which this now follows through, was an interesting issue there was around potential conflicts of interest or governance around separation. So, I'm sure everybody on this call has a different take, but in my world with Maggie, I tend to produce clinical safety case reports. It works best if I'm able to share them and get people to own, understand, and take some responsibility for reviewing them and approving them. And that just gives credence and additional governance to the DCB aspiration, really. And here we see a slide with nearly 70% that are having to balance a number of balls in the air. Just an observation, no right or wrong answer.
And it may be something that's maybe something we need to look at, of giving in multiple roles, where are the boundaries of the CSO. I know we often get questions around that, around the clinical safety case report, and what should be in the report and what should be excluded.
So I think one of the things, this is the theme that emerges for me over a lot of the questions, but it starts here, is people are a CSO and a CCIO. And I'm sure you've all read the published job description for a CCIO that was announced yesterday, I think, by the faculty. And that says very clearly it's a senior management executive role, and a CSO, in my view, is an assurance role, and those roles are different. One is an assurance and one is a risk ownership role. So that is something I concerns me a lot, to the point now that if somebody asked me to write a clinical safety case, I'm saying who is receiving that and who is acting on that, because quite often I'm asked, I do a lot of consultancy work for NHS trusts, and they say, can you sign off the clinical safety case report? Well, no, I can't, because I can approve the report. But so where we have those more than one digital health role, as I say, it will come through in more and more questions, but I do not think that a CCIO role and a CSO role are compatible.
Yeah, I tend to agree with that, actually. Okay. And just going to move on to the next one. So how much time? This is quite interesting, actually, the time elements of this. So we had kind of these are the options available. I think we said the option of a full-time, half-time, or kind of on 10 hours per week. So these are the time spent. We're often asked about how much time should a jobbing CSO be spending on their job or their role, and this is measured in different units, isn't it? Units of measure. Sometimes it can be a PA, a professional activity. Sometimes it could be a session, or sometimes it can be measured in numbers of hours per week. But I know in most trusts, most of the CSOs are assigned one PA or half a PA to do the job, if they're lucky. So it is very variable. Interesting. The majority is under this 10 hours per week, really. And I think it's something that is an area of sometimes concern. What we didn't ask here is about, are you in a shared role, which some trusts I know have shared CSOs. So you may be sharing the role, or have two CSOs within a trust. And I know some of our local trusts in East Anglia have two CSOs now, just because of the commitment of the job, really. And I know, Maggie, did you have any comments from your kind of from your angle on this one? Because is that on the number of hours?
Only that I don't think one person in a moderately sized trust can undertake that role as it exists at the moment. I think I'm sort of developing a model of a devolved devolved responsibility, and how we make clinical safety part of the way we do things. And as clinical safety officer, I think full-time a single clinical safety officer might oversee all that, but certainly can't do it all. Yeah. So it's a bit worrying.
Yeah, And I think this comes back to supporting the role and see what the faculty can do about that. And this rolls kind of nicely onto the next question we asked. How many years have you been in your role?
Sebastian, could you just remind me what slide number we're on? Because I'm jotting it down. I can't see it on the screen.
Yeah, so we're now on the slide 8.
8.
How many
Okay.
years have you been in your role? So the results are there really. So I think we're seeing an increasing number of CSOs who've been here kind of a shorter period of time as older folk move on, leave, but quite a few people have been around for a number of years now. But I think my main point about this slide, I suppose, is trying to say to you all, well, how are we trying to assist you in your role if you're less than 1 year? Because it's all new. It's a very responsible position, and it's not until something happens with your IT system that you really feel I suppose the pressure of this. And so how can we as a faculty support that? And so just give some thought to that, so we can think about that in our kind of summary session at the end. And I think, Clive, you had a comment about that as well.
Yeah, I think for all the slides, actually, this was the most interesting one for me. So to your point, Sebastian, with my day job, I also work as a director for another company, and part of that company is try to build the next generation of clinical safety officers. And you're absolutely right. You know, it's not until you've had perhaps an IT crash with a number of clinical systems going offline that the pressure really can be quite intense. And then the demand on your time and your ability to make decisions can be difficult, particularly with some very senior people. And it's all very well writing safety cases and doing some proactive stuff, but maybe there's a skill set about how to deal with things when they go less well, where sometimes experience can be of value. And I think this slide suggests to me that maybe the faculty has the opportunity maybe to develop a young CSO or aspiring CSO club of interest, maybe the opportunity for some mentorship. And again, as people think about what we've asked them to do at the beginning in terms of giving us ideas, I just thought this slide told me a lot about the next generation of clinical safety officers.
Yeah. I think, and they're all good points. And I think also the ability to say no, and we often see this in the clinical safety group, CSG and NHS Digital. Actually, if you are a CSO in a trust and you're being asked to sign off a product and say it's safe, it's clinically safe to deploy, it may not be your final decision, but I think you have to be in that position to be able to say, actually, you don't consider this particular IT solution to be safe, that there's not enough evidence, or there's not enough testing being done, or whatever the reason. So I think it's having that confidence to do that, and having some fallback mechanism to ask for a second opinion sometimes, because
and Sebastian, a good example of that, and Maggie and I have had recent experience of this, is I work for a trust also, and sometimes I'm put in this insidious position where another part of the organization, particularly because of COVID and the acceleration of technology, has asked to deploy a system. That system has no DPA, no governance, no DCB 129. And to your point, Sebastian, it's sometimes being quite brave to say, actually, the starting point is this system is actually fit for purpose, and having the wherewithal to be able to evidence and say no. And I think that's equally an important skill set, to be able to have that ability and reflection to be able to say, this is not perhaps the right decision.
Yeah.
There's a couple of comments on the chat. I'm first just a respect to Michael Krieger, who introduced himself as a digital troublemaker, and I wonder whether that should be part of the job description, because actually that's what you have to be. And to Clive's point about being able to say no, sometimes in the role I'm in, I'm expected to go in there and not bring bad news, because where the way CSUs work is we go out to customers. So I've had to pull on my professional accountability, say I cannot say that's safe, even if commercially or whatever it is, commercial is not quite right, even if everybody wants me to make things happen. So there's that professional accountability piece. But I'm just going to go back to Becky Taylor and to Kerry. Becky Taylor, Becky, I can't see where you work because I can't scroll up and look at this at the same time. They have 5 trained clinicians who have individual responsibility for various projects and do support each other. But what I think is worrying, Becky, is you say producing the CSE can feel stressful due to other commitments, and that's 2 things that bother me about that. First of all, that producing a CSE should take so much time, but this is probably to another point, and it's certainly something I feel passionate about. I think some people feel that, or some people expect an exam paper or something. So as a clinical safety case report, they are difficult to produce, they are hard work, and you've got other commitments. That's maybe something that we could explore perhaps later on in the SIG. And Kerry, who said that she's looking to share work between the junior CSO as well as working with established CSO team members and create a structured approach within the team. So that's really, really positive. And Kerry, I mean, I don't know whether at some point, but perhaps we could hear from you and see how you're structuring that. And I'm not quite certain where you work, but that's really good news. Just looking at Anne, yes, Anne, it can be challenging to know what you're being asked to sign off as you don't know what you sometimes don't know, and that's I hear that in my informal conversations with people, is that they're being asked to sign off something they know nothing about. A lot of pressure to move things on. So I think there's what's emerging is a little bit of a picture that I've heard before about the clinical safety being somebody magic who can come in and just sign something and say, yes, that's now safe. And as you know everything about safety, when actually clinical safety is a process over which you are looking and you want evidence of that everybody knows it's safe. So again, something possibly, I can't quite capture that, but I'll give it some thinking and come back to that point again.
Yeah, the end, Maggie, as well. So that's important, I think.
Yeah. Yeah. Okay.
I'm going to roll on to the next slide because we're going to.
Yeah. Sorry.
I know we've got to keep going through these, but it's just this next thing was, who do you report to? Who do you escalate your clinical safety concerns? But so this was just an open question. There were a variety of similar answers, but generally kind of to a senior level, but there didn't seem to be any kind of particular individual that a CSO would report to. Sometimes it'd be the director, clinical director, business manager. So I think that's another. And there was this. I think one of the talks earlier mentioned about standardization, and I think trusts all their individual organizations. So they have their own individual reporting mechanisms, but it'd be nice to have some guidance, I suppose, for trusts, if when they're producing some sort of job description of ideally who should that CSO be reporting to. It'd be nice to do that, I think.
And if you're working in an ICS, that may or may not be an actual organisation who you report to. And I think there's one thing about working in trusts which have a from the outside, I'm sure it looks very homogenous. From the inside, I'm sure it's quite fractured. But at least you have there's a line of accountability. If you're working in an ICS or any other sort of nominal health and care system, it can be quite hard to know where the clinical safety function sits.
Yeah. Okay. As I say, as we're going through these, do keep thinking about how can the faculty help in all these things, rather than me just reading out the answers, and we wanted some interaction. So if there are any general questions, do keep bombarding Maggie with a chat. She's very good at keeping up with this. So she's got expert skill. Okay, there we go. So next question was, this is interesting, isn't it? Was there a formal selection process for your role? Yes and no. It's kind of 50-50 split. I get the feeling some of the so some of the legacy or maybe slightly older CSOs have never had. They were just saying, "Oh, try Clive. He'll do the job," or I think within NHS Digital there were formal selection process, but actually in the CSOs with trusts, I think someone is just expresses an interest and is then placed in the role. So interesting.
Or just don't step back quickly enough.
Yes, maybe. And I think the question here, Clive, you mentioned, or Maggie, what you had a comment on this one, didn't you? About
I think I probably added to that because we didn't ask the question about a job description and what job descriptions there were. And I think a job description assumes that the people who are employing you know what a clinical safety officer does. So I think sometimes they reverse engineer a job description. But again, I think that may be something, as I mentioned before, the faculty has just come up with a job description for a CCIO, perhaps a job description for a CSO, or a number of situations in which clinical safety officers may be working to say what a job description might look like.
Yeah.
And sorry, just adding to that, Sebastian, and I suppose for me a little bit of a caution there is, let's not get too excited about job functions, job descriptions. What's equally as important is the governance arrangements about thinking where that particular person sits within the organization in terms of influence, in terms of responsibility and accountability, reporting lines. Yeah. And again, I think that goes to some of the earlier themes we were talking around about wider governance and making sure that someone is part of a team, making sure somebody is professionally loved and supported, has an escalation point, knows, to our discussion earlier, if they're producing safety cases, then they're being appropriately reviewed by other people and signed off and owned by the organization. And sometimes people get very obsessed with the job description, give little or no thought as to where that person gets parachuted into the role. And in that can unintentionally cause the most horrendous problems, which are, if it had been thought through, might have been easier.
Yeah, I agree. Just really next slide was the are you involved in the whole system life cycle? So 64% involved in pre-procurements. Some yeses are aspirational. Supplier input depends on client. And some quotes here as well. In theory, but we lack the capacity, not formally until we just before we go live. Interesting, isn't it? That's yeah. So this thing about early involvement so important, isn't it?
And again, what is a life cycle? Because that's to the end. If you look at the standard, it says till decommissioning. We never decommission anything. We just let it rot in the garden, don't we? Really. Yeah. But who was responsible for? I think my question was, who was responsible for the life cycle of that whole system? Who is responsible for? Is it down to the clinical safety officer to say, oh, this thing needs to be reviewing, or is there a product owner who says we must review the training, we must review the business processes, we must have a review of the clinical safety? To my mind, that's another thing. That sort of I hesitate to say product owner because that's used in Agile and means something else. But when a system, does it sit in IT, but it's a clinical system? So should the product owner be a clinician? Should they be a clinical informatician? So all those things, who's looking after that product for end to end, making certain it's still doing what it was intended and we haven't added other functionality without anybody knowing. So who's responsible for that software in the context in which it's being used?
Yeah, I think it's a difficult one to answer. Who actually is this the CSO to be involved? I think it's about the involvement and the pre-procurement so important, but the variety. Okay, I'm just going to move on to the next question because I'm aware of time again. So, are the DCB? And just so we've got another 5 questions to go. So just so you know, folks. Are the DCB 0160 requirements set out in your organization risk management process? Yeah, so generally, yes. So it was encouraging. And I suppose coming back to my comment on this would be, has a faculty got a role here at all by trying to promote these standards within for organizations. We don't make much contact with actual organizations. It's all through our members at the moment. Is that right or wrong? So don't know the answer to that, but it was it worried me. There were 35% said no. So I think,
is there something there also that the as the standard currently exists, that the hazard log is based on a matrix that NHS Digital has devised, and yet there's a National Patient Safety Agency one, which is ever so slightly but quite a lot different, and an organisation may have something else. And we know projects have risks, things that they have to do, but often they're just ticky boxes. Let's think of a risk and who might own it, and then we can get that bit done. So I think that there is a big piece to discuss around this about how does what we want to do in clinical safety, and we have to be quite detailed about hazards and causes so we can identify the mitigations. How does that fit into existing risk management processes, and why would we not be using the National Patient Safety Agency matrix? So lots of questions around that about risk management's approaches.
And then the next one was just moving on. Do all your systems have a current clinical risk management plan? So over a third do, but then a lot don't. And I think this may be about all the systems and the legacy systems, Clive, that you picked up on. This is about legacy, maybe, and as new systems come in, they maybe have the safety work done, but legacy systems that, certainly in my experience, haven't had that performed often.
Yeah, and it's an interesting point. I'm doing some work down the West Country, and what I've looked at is a schematic or a topology of all the systems they've got, legacy, new, or otherwise. And I think I counted in the topography over 300 different clinical systems. Wow. So the significance of a plan becomes very important in terms of, if people are only working 10 hours a week, how do you prioritize what needs to be done? What are the points of urgency in terms of things like, where these systems actually coalesce, or the integration points, and many other things. And I think unless you've got a plan of work that determines how a resource is going to be deployed to ensure the ongoing safety of both legacy and new systems, then you're not going to really get too much clinical executive buy-in to do the work. So yeah. I just sit back and often say, if you don't have a plan, you don't have something to fall back on to say, look, that's what we agreed to do. And you're then thrown from pillar to post. That was my only observation.
Yeah. And once you have a plan, it's one thing having it, and this is what worries me about a little bit about the standard documentation, is they ask for a plan and people submit all kinds of things for a plan. A plan's a plan. It's a bit like a burst plan or an end of life plan. It doesn't survive first contact with the enemy, does it? Or it doesn't. It isn't even. The plan's written. They think, oh, good, we've got a plan, and nothing else happens. So, are those activities being carried out in a planned way? I think is possibly we might. And I personally would like to be changing the language within, especially 0160, to say, not have we got the clinical safety case report, but can we communicate the activities and the residual risk? Have we got a plan and are we undertaking it, and do you know whose responsibility it is? So moving away from the compliance of the documentation tick or fail to, are we doing that activities? Now I think if we start changing the language, then some of you guys who are out there who've got hundreds of systems, it may be not your job to do it, but it may be you tell people what they need to do when they're doing it.
So Maggie, again, bearing in mind there are 20 plus people who have contribution to make, here's an idea, here's a throwaway comment, and I'll be contentious. Could the faculty support create the creation of a sort of 2-page simple plan. You know, what's good practice? What would you expect to see in one? Might that be a help? You know, the DCB 129 thing is a little vague over the planning, but maybe it needs a little bit of sort of oomph and sort of simplification. I'm just trying to throw in some opportunities to progress some work of value.
Yeah. Now, what I'm going to do, Clive and Maggie, now I'm going to run through these last few quite quickly. So I want to give time for comment at the end, and I've got a clock ticking in front of me. As always here. So just the next one was clinical safety case reports. Who writes them, who validates them, who accepts recommendations. So this is interesting, I think, around who's writing them, who validates them often, who accepts recommendations. And this was just an open field question, so it was just something that people would put in comments of who's writing them. And I think, as we know, the clinical safety officer doesn't have to write the clinical safety case report, but it's actually usually is validated or approved by them. I think just to get you thinking about, is there some more work the faculty needs to do around this, around the clinical safety case report writing? There's some organisations find it difficult, some easy. It takes time. What's the best way of addressing that? And while you're thinking about that, I'm going to move on to the next question. Do others in the organisation know what clinical risk management is? Yes, and yeah, kind of a yes and no here. Is this something the faculty should be looking at, or is it just beyond remit? I'm just thinking about new emerging organisations, especially around ICSs. I think are going to present a particular challenge to us in the safety in safety. I'm just going to move on to the next. Do others feel that clinical risk management is their responsibility? Yes and no. I think there's a bit of my reading of this is others in the organisation, but may be read differently by the respondents, possibly.
I do think it's significant in the quotes there, Sebastian. So I know you want to illustrate it, but the cultural piece, it is a cultural thing that needs to happen. It's that devolved responsibility, like washing your hands.
And we had thing on safety incidents question. How do you log safety incidents? What reporting systems do you use? Both have similar answers, mainly generic, using Datex, sometimes help desks, and sometimes Jira. So again, I suppose the question here to you, should we be putting more effort into standardizing reporting? I know actually gathering information, reporting clinical safety incidents is often variably reported by trusts. And is there a role for NHS England, the National Patient NAPSAC, National Agency for Patient Safety, for them to do some more work around this, or the faculty? I'm going to move us on again. Can you find relevant information and knowledge? So NHS Digital, FCI mentoring. Too much information, someone said, in different places, and difficult to keep up. Yeah, interesting. Find the software as a medical device extremely difficult to interpret. I agree with that, actually.
Yeah.
Very important. I think, again, think about how we can help assist with that.
And a conflict between that and some, because software as medical device demands an ISO standard as well. So sometimes they don't come with an 0160. It's difficult to do 0160 because you haven't got the right information.
Okay, this is interesting, isn't it? Is the information and knowledge easy to apply, complex and bureaucratic? Quotes, wording and document overly confusing and large. Juggling long and time consuming, feels like a burden. So yeah, that's a concern, I think, something we need to look at. And again, I don't know whether there's anything coming through on the chat on this, Maggie. We're on
I know.
information
Just
easy to find.
Neil is asking whether incidents should be reported to the NRLS, and I would challenge you that, Neil, I don't know what the NRLS is, but probably it should. So I think that shows how clinical safety
Maggie,
officers.
it's the National Reporting and Learning System, a great,
yes, exactly.
MPSA give, wasn't it, back in the day?
Well, exactly. But what I'm saying is we don't know. A lot of people don't. You come in sideways into this job and you don't know all these things, yeah. So that's where we are.
Okay. So that's the end. That was the end of the questionnaire. So I want to give us 5 minutes. I knew this would run over, but I think I think for some thoughts from the group of what we can be doing to help. Is there anybody else within this group who can help us with dissemination of ideas? What could the faculty be doing? And in particular, this thing about facilitating good practice, the mentorship and leadership stuff around the CSO role, and sample job descriptions perhaps, and some more guidance around the clinical safety case report writing. So I'm just going to stop sharing now for a second and just going to see if there's any general comments or thoughts or any direct questions to us, because Clive, Maggie and myself have been talking at you for the last 30 minutes. I hope you found that slightly interesting around this, but it's something which I think the faculty should be doing more of, actually trying to survey our membership about how the faculty should be developing, what areas it should be developing in.
So we've got Michael talking about the CSO role. We have got Anne said, could we produce some top tips, best practice standards or examples for frequently asked questions, frequently raised concerns? And yes, Anne, we thought about that. We won't do it, but I think that's really important. And I think the thing is to make certain it's done in a forum or fora where those things, because I look at a discourse and I lose what's going on. Somebody else is asking for templates for clinical risk management plan, and I think that's interesting. I think that we probably need some templates for all the documentation, review some of it, because I think it's a little bit complex. So that's what they're asking for. In a flow chart of what clinical assessments a new digital project has to go through. I think that's a good one, Petra. Barbara is asking a general question. It's not about what we can do, but asking about digital clinical safety assessments, new data dashboards. And I think that, Barbara, if you don't mind, I think that's a really useful way of illustration of when does it apply. And I think it applies every time we think it's going to affect patient care. And I think there are some discussions about that, but I think we should own those. We, the clinical safety officers. Michael, if you go to the website and go to the clinical safety, go to the SIGs, you can join there. You may have done already. You should get the invitations, but sharing of safety cases.
Oh. And Max, sorry to interrupt. There's a meeting coming up, isn't there, in October? Later.
Yes.
Yeah, the next SIG. I think it's the 21st of October.
It is, yes. Anybody who wants to go and who thinks or they're not or wants to be part, but the group, go and join that, and we will try and get the invitations out to everybody.
Yeah, I think a good meeting. We've got NHSX talking about the DTAC standards. So it'll be interesting. Were there any other kind of general comments, kind of voice comments we can? Anybody else wanted to kind of say anything about how we can develop the faculty SIG? Because I think it's a really they're supporting us to support the SIG group. So anything we can be doing to make your job easier, apart from having our SIG meetings. But I was thinking around this kind of central repository for information, kind of quick chat lines of some sort.
Barbara's looking about digital clinical safety policies. Or the models out there, taking that into account, that'd be useful. Strategies and policies. I'm quite keen on helping rewrite the standards or help operationalizing the standards. I mean, you know, they're good standards, but we're using them. We're all confused about what things mean. Should we say, actually, we'd like to review the standards and make them a little bit more doable?
Or have faculty input into that.
Input into it, yeah.
Sebastian, another observation which I've done for a few organizations is, I must admit I'm not a great policy person. For me it's BBC bite size. Our checklists, so a DTB 160 checklist. Here you are, 3 pages of what you need to know when some vendor gives you a safety case. Yeah. What's bad, what's good, what should you look for, what shouldn't you look for, top tips. So here, classic example, never accept from a vendor a safety case with a hazard log that isn't in Excel format. Pretty useless if you got it in a PDF. You can't manipulate it. So go away and give me one in Excel. There's a top tip, So
also, never trust people who say they've reduced everything to acceptable, because they probably haven't.
Just to let you know, this room will close automatically in about 10 seconds. So sorry to.
Thanks, guys. I've got all your I've written things down. Thank you so much for your comments.
We haven't given you much time to speak, Andy. I know you wanted to say something, Andy.
No. Just show me face.
You do have 50 seconds if you did want to say something.
No. I was literally just sort of turning my camera on at the end. So.
But do join the next SIG meeting and keep in touch with us. We're here to kind of support any ideas. We try and take this forwards and try and make things a bit better, a bit easier, a bit better, and more supportive. So give us, think about it and let us know. I'm going to keep going for another 25 seconds to stop. But our next SIG meeting is on the 21st of October, and that we have got NHSX presenting about the DTAC standards, which are interesting and of which I don't think the faculty had any much input into, but we're going to be looking at those. But take